over-the-counter medications, some relative rest, icing, etc. So we'll go over more detailed points in the physical exam during the breakout sessions. We can be a bit more hands-on. But my hope today is just to teach a basic overview of the anatomy to allow you to further narrow the diagnosis. So, just like yesterday in terms of anatomic locations, I tried to break up causes of shoulder pain into different regions. So if somebody presents with shoulder pain throughout their shoulder, you can just kind of pinpoint that, generally speaking. So anterior shoulder pain, typically that's glenohumeral joint osteoarthritis. That may be an old dislocation, which can be a labral tear, and or a bicep tenosynovitis or a partial tear. Lateral shoulder pain along the outer part of the arm here, tends to be more cuff. Rotator cuff bursitis can refer pain to the lateral aspect of the shoulder. So oftentimes patients will come in with pain here, and that's kind of a hallmark for rotator cuff pathology. Posterior shoulder pain tends to be more muscular. Usually it's trapezial, periscapular muscle strain, but sometimes it can be indicative of a labral pathology or labral tear. And superior shoulder pain, there's one joint right on top of the shoulder called the AC joint. That's typically the problem if somebody comes in with more superior located pain. So let's start by talking about rotator cuff pathology. I think that's probably by far the most common presentation to your guys' offices. So incidence of rotator cuff tears, and I apologize, it may be repetitive for later on, so we'll kind of go through this quickly, but rotator cuff tears are common. Certain studies, depending on what you look at, there's a normal percentage of patients who have rotator cuff tears, and some of these are asymptomatic. Some of the more recent studies using ultrasound and or MRI show that anywhere from 19 to 30% of patients will have partial thickness and or full thickness rotator cuff tears, and these patients are asymptomatic. And that percentage definitely increases with age. This MRI study by Schur looked at asymptomatic patients, no shoulder pain. They found almost 30% of these patients had either a partial thickness or full thickness rotator cuff tear. So these things are common, and they're not always a primary pain generator. So what is the rotator cuff? The rotator cuff is a series of 4 muscles and tendons throughout the shoulder that are responsible for forward elevation, bringing the arm up, as well as rotation in and out. There's the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. And these have big, broad insertions on the scapula, and they insert down into their insertion on the humeral head. These insertions are pretty broad. These are strong muscles and tendons, and when these insertions tear, that's a rotator cuff tear. In terms of rotator cuff anatomy, you can see on this side of the screen, this is a normal insertion. That's a pristine-looking rotator cuff. That's a healthy patient. On the right here, and I'm sure we'll see some videos later on in the other presentations, this is a torn and retracted rotator cuff. So, these things can be painful, and clearly something like that has the capacity to provide symptoms in terms of weakness, pain, etc. One point I'd like to make in terms of bone spurs, right? Everybody talks, the doctor said I had a bone spur. Everybody has a bone spur. That's part of your normal anatomy. Everybody's born with an acromion bone, right? And the difference is the shape of that acromion bone. Neer, several decades ago, described different types of acromion shapes, the morphology of the acromion. Type 1 is a flat acromion, type 2 is curved, type 3 is hooked. And what this can do, this can narrow the space where that rotator cuff lives, so it can cause what we call external impingement and or a fraying or pinching of that rotator cuff with repetitive overhead activities. So this can be a contributory factor in terms of rotator cuff tears. We tend to classify these tears based on partial or full thickness tears. The partial tear classification is further broken down into articular-sided or bursal-sided tears, and then we tend to call this low-grade, medium-grade, or high-grade type tears depending on the percentage of rotator cuff that's torn. This is a full-thickness tear here. You can see that fluid gap right through there on the MRI. So why does a rotator cuff tear? This kind of goes back to the anatomy. There's 2 different theories. One is more intrinsic. The other is more extrinsic, and it's probably a combination of both. The extrinsic theory is what Neer described with external type impingement and the morphology of the acromion. There's also a lesser discussed entity called internal impingement. We tend to see that in younger active athletes. So if you have got a patient who's older than 40 with an articular-sided tear, we tend to think that's probably more kind of age-related changes, degenerative changes within the tendon. If you've got a patient who's older than 40 with a bursal-sided tear, typically that's more extrinsic and that subacromial impingement type theory. And then the younger patients tend to develop these intratendinous type tears, and that's kind of specific to the younger overhead type athlete. Most patients will present with pain and stiffness. Believe it or not, sometimes partial thickness tears can actually be more painful than full thickness tears. This was an interesting study that showed that exactly that. These partial thickness tears were more painful than full thickness tears, likely because the body's kind of ability to try and heal these tears, it was releasing these increased levels of pain factors, which I always find interesting that it doesn't quite make sense, but it's kind of a good point to kind of take home. As these partial thickness tears progress to full thickness tears, you can get increasing levels of mechanical symptoms and weakness. Exam, I'm not going to get into details here. Suffice to say that we'll go over a dedicated shoulder exam. Typically, it's rather straightforward. You just do some simple manual muscle motor strength tests. If there's weakness, if there's pain, that's indicative of a cuff tear. And there are some specialized tests you can do to try and delineate, is it cuff, is it labrum, that sort of thing. But even in the well-versed shoulder surgeon, it's still difficult to tell based just on physical exam. Oftentimes, we'll refer for an MRI to kind of further narrow our diagnosis. So let's move on more to anterior shoulder pain. Typically, that's glenohumeral joint, either osteoarthritis in an older patient. A younger patient, it can be a dislocation. So I found a good way to talk about anatomy about the shoulder is talk about dislocation. So there's several ways that the shoulder joint, the ball and socket joint, are stabilized. There's static stabilizers, which include the labrum. The labrum is this ring of tissue here that acts as a gasket on the glenoid. The glenoid is the socket. And that gasket helps keep the ball centered in the socket. The analogy we like to use is the golf ball on a golf tee analogy. And that labrum, which is here, helps deepen that socket by about 50%. It also does form a suction cup type effect, that adhesion-cohesion type effect that helps keep that ball centered in the socket. Also, there's important ligaments throughout the shoulder that confer stability to the shoulder, the most important being the inferior glenohumeral ligament. There's also dynamic stabilizers of the shoulder, which include more of the muscles, the rotator cuff, the deltoid, the bicep, and the scapular stabilizers. That's why sometimes with shoulder instability, we'll send a patient to physical therapy. Well, that's not going to help their static stabilizers. That's going to help their dynamic stabilizers, and that's the intent of that. In terms of risk factors for dislocation, this historically is a young, active patient population. This typically is a contact athlete, a military population. Otherwise, it can occur in laborers, people with falls from height, pulling heavy objects, that sort of thing. There are some inherent risk factors towards which would lend themselves towards dislocations. One is ligamentous laxity. The other is any benign hypermobility syndrome, Marfan's, Ehlers-Danlos. Those patients, without a doubt, are more likely to dislocate their shoulder. Additionally, once you dislocate your shoulder the first time, you're at further risk for a repeat dislocation, without a doubt. By now, we know the shoulder is the most common dislocated joint in the body. Most of these dislocations are out the front, anterior. So when in doubt, just say, yeah, it was an anterior dislocation. You'll get it right 95% of the time. The recurrent instability is an issue that we see a lot more frequently in younger patients. And the reason is they're more active, right? That's the only reason. They're more active. So they're going to put their shoulder at risk for further dislocation. Whenever you dislocate your shoulder, most of the time, the vast majority of the time, you're going to tear your labrum, and that's called a Bankart tear. You guys have heard of, I'm sure, of that term. You may see it on an MRI report, that sort of thing. But a Bankart tear is an anterior-inferior labral tear. That serves as the origin of the inferior glenohumeral ligament. So when that shoulder dislocates, the ligament pulls on the labrum, and the humeral head kind of knocks off that labrum, resulting in a tear, almost always right there. Now, a lot of you have probably heard of the term Hill-Sachs lesion. You probably say, well, you don't know what that is, but all right, we can ignore it. Nonetheless, we generally speaking ignore it unless it's a chronic dislocation. But we see it a lot in shoulder dislocations. Essentially what happens is as that shoulder moves out the front anteriorly, there's an impaction lesion posterolaterally in the humeral head. And it leaves a little bit of a divot because that's soft bone back there. It's a little bit of a divot in the posterolateral humeral head. For the most part, we ignore it. with repetitive dislocations, it does need to be addressed at times. What's also important to note, anybody older than 50 who dislocates their shoulder, it's not uncommon to see a rotator cuff tear, a non-displaced greater tuberosity fracture, so other concomitant injuries, and you want to be suspicious for that. So almost always these patients will get an MRI and or a CT to further identify the nature of this tear. We'll get into the mechanism in some further talks. I think there's a dedicated talk on shoulder instability today, so we'll let the other guys get into that. Lastly, I just want to review the AC joint, acromioclavicular joint. That's otherwise known as a shoulder separation, right? Shoulder dislocation is the glenohumeral joint. A separation is the acromioclavicular joint, and that's the joint up top here. This is actually a joint, right? A lot of people don't know. It's a joint. It's got actually a small meniscus in that joint that can degenerate relatively early in age, but it does undergo translation and rotation. It's quite vulnerable to injury because it's in a subcutaneous location. Typically, it's a younger patient injury. It's much more common in males because we more frequently play contact sports, and it's very common in ice hockey, football, rugby, contact sports. There is stability about that joint conferred by both static and dynamic stabilizers, just like the shoulder. I won't get into too much detail here, but there's AC joint ligaments and there's CC ligaments, both of which add to stability about that joint. Typically, this is injured with a direct blow right onto the point of the shoulder. So if somebody tells you they fell on their shoulder, they've got pain on top of the shoulder, that's an AC joint injury. It's a relatively straightforward diagnosis to make. We classify these injuries based on mechanism, based on degree of displacement and ligament injury. And most of what we'll see is 1s, 2s, and 3s. 4s and 6s are very uncommon. 6s has only been described a handful of times. I've never seen it. I'm sure none of the orthopedic surgeons in the room have seen it. Eric? No? So, from that standpoint, it's rare. Suffice to say that 1s and 2s, conservative treatment. 3s, 50% may need an operation. 5s, always surgical intervention. So that's a referral to an orthopedic surgeon. We'll get an x-ray and we'll either refer to PT or kind of indicate the patient for surgery. The physical exam is very straightforward. This is palpate the joint, and you can do what's called a cross-arm adduction test. If they're tender over that area, that's a home run diagnosis. If you're unclear, you can always inject that joint with lidocaine. If all the pain gets better, that's the diagnosis. If it doesn't get better, you may want to start looking for other reasons of shoulder pain. So I was asked to keep to 10 minutes, so that's my talk today. There'll definitely be some repetition here with the rest of the shoulder talk, so I'm sure we've got time for a quick question or two if we've got it. Go ahead. Yeah. Sure. Yeah, great question. So the impingement tests are rather straightforward. What we're trying to do is just recreate that pinching. What we'll do is we'll forward elevate the arm, we'll apply some internal rotation, and most of the time patients will say, yeah, that's the pain I'm getting, right? And the impingement test for any cuff tendonitis, bursitis is going to be positive. So most people who present to my office with any sort of cuff pathology, the impingement test is going to be positive. The take home here is that if there's a cuff tear, there's going to be weakness. So if you come to my office and we examine you and you've got pain but no weakness, that typically is a diagnosis of cuff tendonitis / impingement / bursitis. It's all one big spectrum. What keys me into is it a tear is weakness, right? So if there's any weakness on exam that's pronounced, meaning using manual muscle motor strength testing can elicit weakness, oftentimes I will get an MRI. I'll get further imaging. So great question. Anything else, guys? Yeah, go ahead. Yeah. At times, yes. You'll have patients perfectly happy with a full-thickness rotator cuff tear, and at times they can be completely asymptomatic. And that kind of begs the question, I'm sure we'll get into it later, what tear needs to be fixed surgically, right? As I mentioned, that number, almost 30% of patients older than 60 may have a partial thickness tear or a full thickness tear and they're asymptomatic. So not all full thickness rotator cuff tears need an operation. And how we kind of parse out who needs surgery and who doesn't is kind of a lot of what we do in the office in terms of, it's absolutely worthwhile trialing conservative treatment with cortisone, with physical therapy, with time, to see if we can allow that patient just to get back to their baseline of a very functional shoulder and avoid an operation. Yeah. So it very much is patient specific. So I think the approach that all of us take, and it's the right approach, is you have to tailor your treatment to the patient, because every patient's different, right? An 18-year-old football player with a primary shoulder dislocation who's going on to play football in college, who's a quarterback, and it's their dominant shoulder, they're going to need an operation to fix that shoulder, right, if they have a primary dislocation. If you've got a 41-year-old who's a weekend warrior who dislocates their shoulder playing basketball with his buddies, he's going to go to rehab, right? And that's despite what I find on MRI, right? So, it's very patient-specific. And I will say that, certainly the trend over the past 10 years has been to be more aggressive with a primary dislocation in terms of surgical intervention if patients meet certain criteria. And that's going back to contact sports, that's age really less than 25. Any young, active athlete, we've got to consider a primary surgical intervention for a first-time dislocator. But it's controversial, and it's always a shared decision between the patient, their parents, myself, and it's a long conversation. That's a half-hour consult in the office saying, here's what the literature shows. These are your options, let's discuss. And it's not an easy decision for patients and parents. So very patient-specific decision. Sure. So the complex interaction between the shoulder muscles that pull to the front, that pull to the back, that pull up, if you can, it's almost like if you were a horse, a jockey, right? Or a better analogy may be kind of if you were riding like a chariot, like I'm not sure what they're called, but you get my point. If you're riding on the back and you're pulling, right, the reins, right? If you pull one way, the horse is going to go that way. You pull that way, it's going to go that way. If you can get some balance there, right, where you can stabilize the front and the back and the top, you can leave that shoulders well balanced and well stabilized. So if you can balance the pull of those muscles, that can impart stability to the shoulder. And you can make up for perhaps a labral tear or other pathology, maybe some glenoid bone loss, that sort of thing. You can overcome some of that with physical therapy. Does that make sense? Yeah. Yeah, so was that with a full thickness rotator cuff tear? Yeah, I would tell you that, that's a very good question, and for me, it depends on what our treatment plan is going to be. So I know somebody has a full thickness rotator cuff tear, and I know that surgery is not an option, whether it's because they can't undergo an operation from a health standpoint, whether they're not motivated to undergo an operation. They tell me, Doc, I can't do 6 months of physical therapy. I can't do it. They can't comply with physical therapy. I'll certainly offer them a cortisone injection and physical therapy, and we can often improve their symptoms quite a bit. And they may have some residual weakness in their shoulder, but you know what? They're able to live their life and do their activities of daily living, and that's a great treatment option for them. So what you don't want to do is you don't want to give cortisone in a traumatic full thickness tear in a 45-year-old, because what you're asking is that for that patient then to feel good temporarily, perhaps worsen that tear, and then 6 to 9 months or a year later come back and, well, we should have fixed this, 6 to 9 months ago. So, when used properly, cortisone can be a very effective modality. All right, guys. Thanks. You're welcome. Thanks.